this COVID vaccine equity task force, and I have a couple of usual announcements. So the task force operates in compliance with the Kansas Open Meeting Act. This meeting is being recorded and live streamed on KDHE's YouTube channel. Please mute yourselves when not speaking to prevent audio interference. So I wanted to welcome any new participants and hello to all to the people that have been on these calls before. My name is Jimena Garcia, and I'm the governor's senior advisor for vaccine equity. And I'm going to be leading this discussion today together with my colleagues from KDHE and KU Medical Center. So to start out, Vicki, if you don't mind putting the agenda up, I would like to just do a quick review of the agenda. I forget that makes my notes go away. Okay, so we're going to start with introductions of new members. Then we're going to go to Courtney Hayden, who will share a brief overview of the plans that we have for this year's task force meetings. Then I'm going to spend a few minutes sharing what I know about the end of the public health emergency order and what that means for us in Kansas, and also about where we are with COVID infections in the state. From there, Jamie Gable, a senior epidemiologist at KDHE, will walk us through the new vaccine data. And now we have race and ethnicity data for the bivalent boosters, which is interesting. After Jamie, we'll hear from our own wonderful state health officer, Joan Duvey, who's going to share updates from KDHE, including legislative priorities. And then the last third of the meeting, we have reserved for our featured guest speaker, Matthew Newman, who's going to share some perspectives about how the history of the HIV epidemic has impacted the culture of the queer community as it relates to the modern day pandemic of COVID. So if you don't mind taking down the slides, Vicki, let's start with quick intros. So if you're attending this meeting for the first time today, would love to hear a few words from you. Please tell us your name, your organization, and your GLOW, which is 5 words or fewer describing something you're passionate about. If you're a regular member of the task force, please put your name and organization in the chat. So I'll open the floor to any first-time attendees, and maybe I will share my GLOW to give people a minute to think. So my passion is childhood hunger that goes on right under our noses right here in Kansas, and I could go on and on about that. So I'll now open the floor to anybody who's here for the first time.
Hello, my name is Alexandra Oropesa, and I'm with Mercy and Truth. And let's see, my passion, I would have to say childhood development and parenting and how those two go together, whether it's a mother, father by birth or a guardian. It's my passion. And so working with people who don't speak English as a primary language is also a passion that comes along with that. Thank you. I'm happy to be here.
Thank you for joining and thank you for sharing. Is there anybody else?
I can introduce myself. My name is Becky Prawl. I'm with KDHE's immunization program, taking over the program manager role that Allison Alejos previously held. My GLOW is vaccines and preventing vaccine preventable diseases. My son had a really severe illness in 2009 with H1N1, and my passion is that other parents never have to experience what that feels like.
Thank you, Becky. Do we have anybody else? Okay. So I will now pass the floor to Courtney Hayden from KDHE to walk through an overview of where we're hoping to go with these meetings this year.
Good afternoon, everyone. It is really exciting for me to see the names rolling in. So if we at some point had a conversation where I invited you to come to this meeting and or you were here long before I was, I just want to say thanks for sticking with us into the beginning of another year. I know that, this started as a COVID conversation, but what you're going to see is that we're really expanding the way that we're thinking about the conversations that we can have here. And that is completely informed by really the bulk of our 2022 COVID season. So on this page, you're going to see that we've chosen an overarching theme of intersectional allyship. And if that just sounds like alphabet soup to you, don't worry, like a little foreshadowing, because in a few slides, we're just going to introduce what both of those terms mean in this context of engaging across culture and identity. So a little bit of a foreshadow. And then we want to divide the year into 3 separate topic sections. So February through April, we're really going to look at the current state of public health. And you may notice that the second column is labeled potential areas of focus. And that's because, as we did last year, we're planning to take an incredibly iterative approach. So we'll plan the month, we're going to have our topics, and then we're really going to be listening for what you as members of this group want to give feedback on, where you want to see more information. So in this first section, we're looking at, hey, let's talk about the status of monkeypox. Let's talk about the status of COVID-19 boosters, because we can remember from the end of last year that those rates weren't changing a ton. And then you're going to start to see some of this language around the LGBTQIA+ community. And that leads us into May through July, where we're going to do cultural highlights in a pandemic context. So really looking at Indigenous history with public health and government, institutions, and impact on how folks engage in a pandemic. And then again, in August and November, we want to specifically do a highlight on the Hispanic and Latinx community, perhaps the Asian community, and that history of public health and government institution and impact on engagement with pandemics. As well as the African American community, we want to continue that conversation that we had with Dr. Glenn towards the end of last year as well. So there's example breakout questions, but really just want to highlight that we're taking an iterative approach and trying to be responsive. So if you hear something in this meeting that you want to hear more of, or you think that we should shift things one way or the other, you can always get in touch with me by email. Thank you, Ms. Vicki.
Thank you, Courtney. Okay, I'm going to spend the next 5 minutes sharing with you what I know about the end of the public health emergency and also update you on the situation around COVID in Kansas. So as many of you probably know, the public health emergency ends on May 11th. And broadly, it's going to end some of the flexibilities within the healthcare system. So 2 things that were tied to the public health emergency are telehealth and Medicaid eligibility. And the good news is that telehealth is going to continue for now. So telehealth measures have been largely extended through the end of next year. And then in terms of Medicaid, so during the public health emergency, nobody had their coverage terminated from Medicaid. But with the end of the public health emergency, eligibility verification is going to resume. So that means that people with Medicaid will have to verify whether they are still eligible. And this is likely going to be a little bit of a messy process since some people's contact information has changed and might not even know that they have to reapply, and then their coverage could end without them knowing. Excuse me. Also, some people who have been covered during the pandemic are no longer going to be eligible for Medicaid and then are going to be left without coverage. So that's going to be a process that goes on over a few months. What things will not go away right on May 11th? And first is free vaccines. They're not going to go away immediately, and neither will emergency use products like antiviral. So these are going to remain available until the federal funds run out for these. And we don't know an exact timeline of this, but the thought is somewhere in the late summer. The supply of free antivirals like Paxlovid will likely also last through summer, early fall. One thing is that if a new vaccine comes out in the fall, those vaccines are likely no longer going to be free. In terms of people access to treatment, there's work being done around access to treatments, vaccines, and tests for people who are uninsured. In Kansas, we have the volunteer testing program and the community testing program, which both will continue to be offered and will be free. We also have the ACT program, which provides home tests by mail, and these will continue through sometime this summer. The one thing that is no longer going to be available as of May 11th are the 8 free COVID tests per month that people with Medicare, Medicaid, and private insurance were able to get. So that's kind of like a short synopsis of all that. I want to just move now to the state of COVID infection. Vicki, if you could please put the slides back. So we're at a point now in the country where case rates, hospitalizations, and deaths are all decreasing. Also, the same goes for the state of Kansas. So this first slide is a map that shows cases per 100,000 people by state, and the darker blue represents a higher number of cases. Next slide, please. This is a list of the states and territories with the highest daily average of cases per 100,000 people. So you can see for the United States, the average is 12 cases per 100,000. And if you look down at the states and territories, like the highest one would be Rhode Island with 22, and the number decreases as we go down the list. Next slide, please. Here you can see Kansas. So we're at 10, which is below the national average. So yay for Kansas. Next slide, please. Here's a map of Kansas counties as defined by the CDC community levels. Most of the state is in green with a few exceptions that are yellow and red that you can see on the map. So with that, I'm going to pass the floor to Jamie Gable, our favorite senior epidemiologist at KDHE, to share the newest COVID vaccine data.
Thanks, Dr. Garcia. You can go ahead and put my first slide up. And I apologize, I'm going to turn off my video while I talk because my notes are kind of the way my screen's set up. You would be looking at the side of my head the whole time. So most of our vaccination categories for all of our age groups have not increased very substantially. Bivalent uptake is highest in older adults, which would be expected. And for adults age 18 and older, we're only at about 15%, which is really overall pretty low. And tender age, which was approved in December, is at less than 1%. So we really have a very low uptake there, and our full series for tender age is only at 5%. So we don't expect the bivalent to be very high for that, but we would of course like it to be higher than what it is. And we're going to go over a more in-depth breakdown of some of the bivalent uptake in the last 2 slides. So next slide, please. So this slide, we have our uptake for under age 18 that have received at least 1 dose of COVID vaccine. As you can see, uptake has changed very little in the past 3 months. The largest increase has been in Asian and Hispanic Latino populations. Next slide, please. So this is a breakdown of how we look at our native vaccination, and this is specifically for under age 18. I've gone through this historically a few times, but I'm going to go ahead and take the time to reiterate some of it now on why we are presenting data in this way, because I realize it might be a little bit confusing and it's been a while since we've met. So I'm just going to go over a little bit more in depth about that today. So our database, KSWebIZ, contains all vaccines that are submitted to us. However, Indian Health Services vaccines are not required to be reported to WebIZ. Some tribal clinics do this and do this very consistently, while others don't. So because of that, we are missing doses that are administered by IHS. And within WebIZ, we also found that we have a lot of natives that will report multiple race groups. So when we report out our data on our dashboards, if you report more than 1 race group, you are categorized into the multiracial category. So we've previously discussed the possibility of presenting data that includes multiracial individuals that have any of their races as native reported to be put into these rates to see if that makes it look more like what we would expect and what our different stakeholders believe would be more accurate for the groups they represent. And so we can talk about that again if anyone would like to. But at this time, this is what it looks like from WebIZ when only native is reported as a race. I know previously, back in the spring of 2022 and prior to that, before our slides were developed by KDHE, some of the IHS data was added to WebIZ data in order to provide just one number so that they looked similar to how our other rates are presented. And the reason that we stopped doing this when KDHE started producing these slides is because there were a couple of assumptions that were being made for that aren't correct. And one is that KDHE doesn't receive any IHS administrations. We do get some IHS administrations into WebIZ, so that was creating duplicates to be counted if we were to do it that way. Another assumption is that all recipients of vaccine at IHS are native, and that's also not the case. And the last assumption is that all individuals that are getting doses through IHS are receiving 2 doses of COVID vaccine. So the way that the IHS data comes in, we don't see any identifiers. We only see the number of doses that were administered. So the method that was being used was that they would divide the doses by 2 and say that would be how many people were vaccinated. And because some people only receive 1 dose and some people are receiving 3 and more doses, that isn't necessarily an accurate way to depict exactly how many people or what percentage of the population has been vaccinated. So for those reasons, we separate these 2 metrics, and we just try to do the additional work to look at the bigger picture and give as much information as we possibly can, as accurately as we can, even though I realize it's frustrating that it's not the ideal way to present that information. But we are happy to continue all discussions to see what we can do to better represent this data. Next slide, please. So this slide is our adult vaccination uptake, so age 18 and older. Adult vaccination uptake has also changed very little in the past 3 months, and this is for receiving 1 dose. You might notice that the Hawaiian and Pacific Islander group actually shows a decrease in coverage. So this is likely due to when an update is made in the racial information in WebIZ to add an additional race, then they would be taken out of the Hawaiian Pacific Islander category and put into the multiracial category. So it is sort of a similar issue that we see with some of our native populations as well. Okay, next slide, please. So this is the native vaccination coverage for adults. It looks similar to how we represent data for the under 18, and the same reasons are why we are representing the data this way. The same issues persist for adults as they do for the children. Next slide, please. So this is probably what we're most interested in. We're seeing bivalent vaccination by race. So these are some new metrics that we're excited to share. Dr. Garcia kindly asked if there were any information that we can share for bivalent by race and ethnicity and by different age groups so that we can see who is best protected from current COVID strains. So older adult coverage is the highest for the white population. Under 18 coverage is highest in Asian populations. For all the metrics, we can see that the 2 populations that we know WebIZ has had some issues categorizing. So Native and Hawaiian Pacific Islander, they show the lowest rates for all the different age groups. So we know that that is not necessarily because they are the lowest, but is possibly because of how race is categorized within WebIZ. So we can continue discussions on how to better categorize that and see what we can best do to reflect what's really the picture. And within the IHS actual data that we do get, we are not able to see any data if it's specific to bivalent vaccine. We only see the doses administered, but it doesn't indicate what kind of dose, unfortunately. All right, next slide, please. And this is the bivalent uptake by ethnicity. So these are presented similarly to the previous slide, but now we're looking at ethnicity. We can see that while Hispanic and Latino populations tend to have higher rates for receiving 1 dose, the rates are actually a little bit lower than non-Hispanic Latino for bivalent vaccine. And when it comes to completing a primary series, Hispanic Latino rates are also slightly lower than non-Hispanic Latino for completing a primary series. So these are the last of my slides, but I will be here for the remainder for any questions. And if we don't immediately know the answer, or it's sort of a longer, more complex question, in the interest of the time for this meeting, we can always get back to you or meet with you later. So please let me know. Thank you.
Thank you. Thank you so much, Jamie. Super helpful. I'd like to now pass the floor to my friend and colleague, Dr. Joan Duvey, our very own state health officer in Kansas, and she has some updates to share.
Thanks, Amanda. And Vicki, I just sent you my slides. I don't know if you want to share them, or I'm happy to share them as well.
If you have them available, it might be best for you to share. Sometimes things move through the server slowly.
Let's see how this goes. Can you see this?
Yeah.
Yeah, it looks great.
Okay, so now here's where sometimes it doesn't work. I'm going to say play from start. Can you see that?
Yeah.
This first slide. You got it?
Yeah.
Did I do it right? Oh my gosh, that has never worked so seamlessly for me. Thanks, everyone. All right, so today I'm going to just do a couple of public health updates. This is in no way meant to be comprehensive, but we'll talk a little bit about legislative updates and then just some public health updates. So the legislative updates I'm going to talk about are listed here. Senate Bill 6, which is Public Health Authority, Senate Bill 20, vaccine limitations, and I won't say much about that because it was not heard in the Senate Health Committee. So I'm not sure if it will stay alive or we'll just never hear about it again, but you never want to say never. House Bill 2007, prohibiting vaccine requirements, which also wasn't heard. House Bill 2390, which is a harm reduction bill that KDHE actually worked with the governor's office to and the House to get a hearing on.
Joan, 1 second. We can still see the first slide, but not.
Okay, so that's what I'm concerned about. Let's stop share and see. And I'm not sure why it does that when I try to share my slides. Let's see.
Oh, that looks better.
You can see the first slide.
Yeah.
Can you see the second slide? now?
Yes, now we can.
Okay,
Yes,
okay.
yes, much better.
Okay, good. Okay, so I am on 2338, Sickle Cell Awareness Week. Was a House Bill 2269, Tobacco 21, 2398, fentanyl penalties and test strips, which was a complementary bill to the harm reduction bill, sort of a backup bill, if you will. 2259, mental health medications and Medicaid, and 2264, no patient left alone, which really spoke to visitation of individuals in residential treatment facilities. All right, can you see this slide?
Yes.
Okay, perfect. So this is the one I want to spend a little bit of time on, and this is Senate Bill 6, and this bill is actually very concerning. What it does is it makes further changes to the role of the local health officer and the secretary of KDHE. It removes the quarantine authority for KDHE secretary, which is an authority that we use to prevent the ongoing spread of contagious or infectious diseases. Except for tuberculosis. So they have carved out tuberculosis in this bill. And I think we all know that tuberculosis, sometimes you need to, really make sure that individuals are staying home and not, if they have active pulmonary TB, not out in the community where they are coughing and can transmit that. Becomes really important when we're talking about multi-drug resistant TB or extremely drug resistant TB. So in this bill that was carved out, which I think is a very good thing. Unfortunately, what this doesn't speak to are perhaps those diseases that are maybe not that haven't hit our continent, but things like Ebola or Marburg syndrome, which are hemorrhagic viruses that do flare up in West Africa or Central Africa. and could, I mean, are just a plane ride away actually from the United States, or viruses that we may see in animal populations that haven't yet developed a way to transmit efficiently to human populations or other mammal populations, but are starting to do that. And that would be like avian influenza, pathogenic avian influenza, which, by the way, when it is transmitted from a bird to a human, has a mortality rate of about 50%. But if this bill, it has passed out of the Senate, if this were to also pass out of the House and become law, it would remove the Secretary of KDH's authority to effectively control ongoing transmission. Also, the authority of the local health officer. It also does not require schools to report infectious diseases to the health department. And essentially what it does is it reduces the role of the state and local public health authority to an advisory capacity. So we are able to recommend and to educate, but no regulatory authority. So we're very concerned about this bill. So as I said, that passed out of the Senate last night. 20 was not heard. 2007, these are vaccine bills, were not heard. And Jimena, do you share these with folks so that they will have a chance to take a look at these in more detail?
I don't know if we always do, but we will. We can.
Okay, perfect. And then 2390, that is our harm reduction bill. And I want to say a little bit more about this. What this does is it establishes the Kansas Overdose Fatality Review Board so that we can bring together, specialists, behavioral health specialists, addiction treatment specialists, public health specialists, medical, hospital specialists, and also people who are family members of someone who may have died from an overdose, and perhaps also somebody from the community who is in recovery from a substance use disorder, to take a look from a public health perspective. This is not meant to say, you're guilty, you're not guilty. But what this is meant to do is to take a look at the events surrounding the death of somebody from a drug overdose and try to identify if there are points prior to the death, which with certain interventions, that death might have been prevented. So this is all about preventing future drug overdose deaths. So that was part of this bill, and allowing the use of fentanyl test strips, also test strips for ketamine or GHB, which are date rape drugs. So right now that is illegal. They're considered paraphernalia, but it would remove them from the definition of paraphernalia. And then it does one other thing, and that is it strengthens the liability limitation for people who are using naloxone, which is an opioid reversal drug. So that is the harm reduction bill, and that did pass out of committee as amended. And I don't know if I don't know if it's been heard in the House yet this morning, or if it's passed. I just looked in it, and it hadn't been updated on the legislative site. So stay tuned about that. And then the backup bill also passed out of committee, and essentially what that did was it combined a fentanyl a criminal manufacturing bill with fentanyl test strips, just in case 2390 didn't get passed. It was heard in a different committee in Judiciary, and that did pass out of committee as well. And then 2259, that's the Medicaid bill for mental health medications, did pass out of committee, and it was sent to appropriations. And that allows the providers to prescribe certain mental health medications without having to go through a prior authorization process, and abolishes a committee that was created to sort of direct the prescribing of mental health medications. And then House Bill 2269, that's Tobacco 21, did pass out of committee and was sent to Federal and State Affairs, where it will likely be worked. And then 2338, designating Sickle Cell Disease Awareness Week and requiring KDHE to study and report on topics related to sickle cell disease, did pass out of the House this morning. Okay, so I'm going to talk now. I can't watch, so tell me when I'm running out of time. Okay, please, Jimena.
You have 5 minutes.
Okay, perfect. And I'm just going to quickly review a little bit about COVID-19. As we like to say, just because the public health emergency is ending, it doesn't mean COVID is ending. And the CDC is really trying to ramp up support so that as funding, federal funding, and maybe state activities that are supporting communities that may not be adequately insured or may not have access. As those supports go away, the CDC is trying to ramp up support to make sure that nobody will be without diagnostics, so not without testing, without treatment, and without vaccine. So Jimena showed you the community levels map. This was from yesterday, and it looks pretty good in Kansas. But I will say, don't take those masks off in the grocery store yet, if you're still wearing them. And then the community transmission map, which is what healthcare facilities should be using to determine if people are masking or not. And what the CDC has said, they changed this last fall. If you are a county that has a community transmission in red, then, and you're a healthcare provider, you and your staff should continue to be masking, and your patients should continue to be masking. So you can see that actually about half the state is still in red, and people should be masking in healthcare facilities. And I can tell you that doesn't always happen. Sometimes you have to remind people. What I did also want to say is that I know Dr. Garcia showed you the New York Times data. That data is data that we get reported to the state of Kansas, and we only get reports from our reference labs and from people who are performing point of care tests, like at a pharmacy or at a long-term care facility, that are positive. So we don't have a full, complete picture. We don't get any data from tests that are done by people at home, and we know that more and more people are doing those at-home tests. So I did want to share, and you guys have access to this. This is our syndromic surveillance program. And what this program does is they take a look at emergency department data, and they get over 90% of emergency department data sources from the state of Kansas. And they put that together. And why this helps is that we see when people go to the emergency department because they have symptoms that are, concerning to them for respiratory illness. And then we can see how they were diagnosed. So it gives us a little bit of a glimpse into what really may be going on in the state. So the first one is all respiratory illness. And then down here, you see RSV. And remember, we had that big peak of respiratory syncytial virus with kids and some adults too in the fall. And then COVID is up here on the upper right. And you can see it kind of oscillates back and forth. We had a little bit of though this is the Omicron peak right here last year. None of us will forget that. And then we had a little bit of a peak right in December. And here's where we are now. And you see that maybe it's starting to trend up a bit. And then influenza, and we saw that peak with the RSV, and now that's going down.
Joan, I just want to give you a 1-minute warning. Thanks.
Okay, perfect. So I did want you to know that we are still doing COVID-19 testing around the state. And we now have 311 free testing sites in Kansas. The only counties where we don't have testing sites are these that are surrounded by red. And we are working very, very hard to find testing partners in those counties and really haven't had any luck doing so. We continue to do that though. What we're also doing is offering Paxlovid and Molnupiravir, those COVID antivirals in the pharmacy. We're working with some of our testing partners. They can do your test, and now they are also offering antiviral treatment. So to increase access to antiviral treatment around the state of Kansas. And then one other way, and I'm going to mention this briefly, which is Project ACT. You can get free tests from Project ACT. Anyone across the state has access to them. All you do is put your phone up and scan that little Scantron and fill in some mailing information, and actually Amazon will deliver 5 tests to your house. Okay. Let's see. And I just did want to share one last thing, and this is why I don't think it's a good time to take off your mask. We are seeing that XBB 1.5 variant, which caused a bit of a peak on the eastern coast, and we are now, you can see, I'm starting to see a predominance of XBB 0.1, 0.5 here in Region 7 and in Kansas. And this is very highly contagious, so very easy to transmit. And there's no indication that it causes worse illness, but people are getting sick from this. So
That's
I will
super helpful. Yeah, thank you. And yeah, for the record, I wear my mask when I'm in the grocery store and around a lot of people. Thank you so much. Okay, so I'm going to pass the floor now to Courtney, who's going to spend a couple minutes just talking about intersectional allyship.
Absolutely. Wow, Vicki, you're so fast. I can't even ask you for something because it's already on the screen. Thank you. I do also want to highlight that I know there's a lot of interesting conversation going on in the chat about the legislative session, and I know that not all of the bills that may be on our mind, and bills might not be the right word, but not all of the happenings may have been voiced over. So just an FYI that we have a super tight schedule, and I want to make sure that Matthew Newman has his full time to speak. But I think, sorry, Dr. Himman, I always volunteer you, but at the end of the hour, we'll stick on for a minute. We'll take down the live stream, and that way we can continue the conversation and do justice to it. So with a pause for how important the other things I know are, we can go to the next slide, which should have a nice picture and some text. Perfect. Okay, so I am just going to introduce words and sort of start to poke at the theme. I think I might be frozen. There we go. Of what intersectional allyship means. I expect this to be the beginning of a really long conversation that's fruitful. And I know, again, this is one that it would be much better to have more time to chat about, but we're just introducing the concept. So this idea of what is an ally. So an ally, just put really plainly, is a person who is supporting a community that they are not a member of. And what I want to highlight, and I've seen this across all of the writings I've looked at, all of the conversations that we've all had, is that allyship is active. So it's taking an active role in trying to improve the lived experience of people who have identities outside of our own. I think I can go out on a limb and say everybody in this room has probably been an ally at some point, even just by some of the conversation that's happening in the chat, private and with each other related to the legislative stuff. I know that we are allies. And then what does intersectional mean? So they say that some people think in words and some people think in pictures, and I think in both. So I gave you some words and I gave you a picture in case that's more helpful. But intersectionality really tries to get at the fact that there are many pieces and parts, many different elements that make up the lived experience of one individual. So the little picture to the right, that's not a comprehensive list of elements of a personality or identity that may exist, but they are a few examples. And what we want to start to look at is how these different aspects of us, the identity, overlap to create areas of both privilege and oppression. And it gives us a nuanced window into how people experience the world. So again, just a quick introduction, and thanks to everybody continuing the conversation in the chat and looking forward to it at the end, I would like to introduce Mr. Matthew Newman. I think we can go to the next slide for the sake of, oh, sorry, one back. I don't want to, just in case he has a voiceover. So I just want to say just a really quick intro. So Matt is incredible. I was given his personal cell phone number by another partner, and I called him unannounced. And I introduced myself as a friend of this other partner. And he said, "What can I do for you?" And it turned into, it must have been almost a 90-minute conversation. And I just mentioned to him, you know, "Hey, Matt, we really want to look at how there are these roots of mistrust, or there's roots of experience that we saw play out during the pandemic. And we very specifically wanted to talk a little bit about HIV and AIDS among gay men in the 80s. So with that, I will hand it over to Matt.
Thank you. Thank you so much. I appreciate being here and given the opportunity to speak on this. So, you know, I was born in 1981, so HIV and AIDS is something that, you know, I grew up around. I mean, something we heard about, you know, all of us, you know, is something that's been in our lives. We all know somebody, and all, you know, have relational lived experiences around HIV. If you can go to the next slide, I appreciate it. So HIV actually came to the United States in the 1970s, coming to New York, and then in San Francisco by the end of the decade. So just like all the other diseases that come, like COVID and everything else, it's going to hit where, you know, the airports and the ports are. I mean, it's just in the ship ports. We're going to hit the coastal cities first. HIV did the same thing. If you go to the next slide, please. So when HIV showed up, there was just, you know, they thought it was just this weird pneumonia that kind of hit, and it was hitting not just gay men, but racial minorities, immigrants. But unfortunately, the first name it was given was gay-related immune deficiency, and that was the first mistake, because it really gave a stigma, and then it was nicknamed the gay plague. And many was seen because it was looked at that, it was looked at as maybe as a way to eradicate the gay community, which we know is impossible because gay people are born every day. But the virus did make a good attempt at a generation, and I'm going to show that in a minute. But many feel that because of this first language, and language is important, this first language of calling it GRIDS, the gay-related immune deficiency, it caused a barrier of response, a lack of response, and a lack of trust. And so we have to recognize that that's the history that we come from. That's a mistake that we came from. And as we live and we grow and in society and in medical and everything, we live and we learn and we grow, and we eventually changed it to HIV and AIDS, which is the appropriate language for it. And so we moved past it, but we have to recognize that we had a history there. If you go to the next slide, please. So this is a picture from 2006, and it's the San Francisco Gay Men's Chorus. And all the men dressed in black facing away from you are men that replaced another member of the choir that died from 1980 to 2006 of the AIDS virus. So the 7 men in white facing forward are the 7 surviving members. And this picture doesn't do full justice because the number of men that died from this choir alone, the number is 47 names longer than the members of choir. So that's 47 members that came and replaced somebody that died of AIDS and then died of AIDS themselves. So HIV and AIDS attempted to take out an entire generation of people. And I mean, just to see what it did to one gay men's chorus, but with that, just to see what it did to an entire generation of people that we lost and the impact that we have from that. Next slide, please. So we have to talk about sex education. So because sex education when it comes to HIV and AIDS is how we have to handle this, because safe sex is what's going to take care of HIV. And so, but when this started, the thought was abstinence, abstinence, abstinence. And so my first sex education class was in 1994 in Jetmore, Kansas, a town of 1,000 people, a small town. And the I wasn't even shown a condom. The closest place to get a condom was 26 miles away in Dodge City. And so there wasn't even access to the teenagers. And we were told, if you have sex before you have a heterosexual marriage, then you will most likely get an STD and a high chance of getting HIV and dying. And it was a scare tactic. Have sex, you're going to die. And so I always thought that if you found somebody to marry, you'd have to get tested for HIV before you married them to make sure that they didn't have sex before they got married. And I thought that was the process because that's what we were taught in school. And we weren't taught about safe sex. We weren't taught about homosexual sex. And I want you to think about now in 2023, I don't want to get into it too much, but now in the school system, are we teaching safe homosexual sex and to stop HIV? So, I mean, that's something to think about here 40 years later. We're still missing what we need to do. Next slide, please. So I interviewed some people because I was a younger generation for this virus. And so I talked to somebody from an older generation, and he's been in the Midwest, but he started in Texas, and HIV and AIDS blew up in Texas in 1996 in Austin, Texas. And he said at that time, he lost 8 close friends in 6 years. And I stopped him and I said, so most people have 2 to 3 close friends. So are you saying you were making friends and they were dying, and you were making close friends and they were dying? And he said, yes. He said, you were making friends and they were dying. We were living in a battlefield. We all thought we were going to die. So when you're talking about COVID and monkeypox and any diseases and vaccines and viruses coming up, you have to understand that the people in that generation were highly traumatized by this virus. And people were dying 6 to 9 months from the onset of the virus. They were just rapidly declining. And if you look at New York and San Francisco, and if you look at the history of that, a little knowledge, the reason it switched from GLBT to LGBTQ+, the L moved to the front, is because when the gay men were in hospitals, the nursing staff would not bring in their trays of food, would not take care of them because they were scared they'd get a disease. The lesbian nurses were coming in and taking care of the gay men. Out of respect for the lesbians, the L moved to the front of the acronym. And that's why it's LGBTQ+, because of the lesbians of the time. However, I heard from these stories from the Midwest, that's not how it was in the Midwest. So he said you would get, when you got the virus, you would look at the acronym, and if it was LGBTQ or LGBT, because they didn't have the Q at that time, then they would give you some assistance, but not much, because they didn't feel that it was part of their community's problem. But if it was GLBT, then they felt that it was part of their problem and that they would help. So HIV actually divided the LGBTQ community in the Midwest in the 90s, which is very interesting from how it was in the coastal cities. But however, it still shows that the people that were taking care of the LGBTQ+ community was the LGBTQ+ community. And so when you are moving forward as government, state, you have to understand that there is that level of mistrust because of the past of who's stepping forward, because there was drugs that that was coming available, but it was getting stuck in FDA. And then when it was getting passed, it was only for people with medical insurance or wealthy. And it was so much that the queer organizations were going in after people died and with family permission and taking these medications, these life-saving medications, and then giving it to people without health insurance. So, but if you think if they filled it on a Monday and died on a Tuesday, they're only taking 29 pills to somebody else. And so you're not doing much for that other person, but they were just grasping at straws to help people. So if you'll go to the next slide. So what now? So, you know, why are we having this discussion? What now? So I just, you all grew up around HIV. You all grew up around AIDS. I'm sure you all know somebody that has HIV or AIDS, but know that because of the past, the stigma is still there. I also interviewed a woman with HIV because I wanted to get a different perspective, and the level of gay hate that woman had because she received HIV from a bisexual man, but she still felt that it was a gay disease from the misinformation, and she has the virus. And so I couldn't use much of her information other than the fact that the fact that she still was misinformed in 2023. And so we need to be conscious of the fact that misinformation is out there. We need to be conscious of the fact that we've screwed up in the past. And we need to be conscious of the fact that there is an entire generation that has been scorned and traumatized. And so when you do move forward, you need to be conscious and respectful of that. And so that's what I have for you. And I appreciate you all letting me talk to you.
Thank you so much, Matt. So useful. What I was thinking we could do maybe is adjourn formally, and then if we want to stay on for questions, we could do that. So we're going to be having these meetings monthly, usually the last Thursday of the month, but we'll send a calendar. And so I think we can formally adjourn.